Greetings, my name is Vineet Arora and I'm a physician at the University of Chicago where I'm Associate Chief Medical Officer. And today I just talked about handoffs here at the American College of Physicians. And so a few take-home points around handoffs are that we tend to think of a handoff as a very long and involved conversation. The truth of it is the best handoff is less is more. So really emphasize those to-dos and if-then items during your handoffs. Focus on the sickest patients, and you can increase the capacity for the receiver to understand what you're saying through chunking. So focus on the sickest patients, then the ones that have action items or to-dos, and then it's okay to kind of let people know that you don't expect anything else on the patients that are on the rest of your list. For the receivers, make sure that you actively listen and try to limit interruptions so that you can stay focused, as well as use a system to keep track of your to-do items. And if you happen to be a program leader, think about scheduling overlapping shifts so that there's time for the handoff, as well as somebody who can help with limiting interruptions and making sure that there is that dedicated space and time for a handoff to occur. Thank you. So I often get asked about whether or not a verbal handoff is necessary, especially in the day and age of electronic health records and technology. And so you heard it here first, technology does not substitute for a successful communication act. You can all have something written in your electronic health record that nobody reads. And so if you really want to ensure that it's a high priority information that needs to be handed off, you're going to need to have a verbal conversation, but it can be brief. So everyone is looking for a magic bullet for handoffs, whether it be SBAR or iPass or a technology fix or a template. And the key is use something. Use a structured template, but it's going to need to be customized for the specific situation. For example, emergency medicine to internal medicine hospitalist may be very different than ICU to ward. And so the key is work with the frontline clinicians to make sure that the critical information is passed off in whatever template that you choose.